Good morning, everyone. I have the very difficult job of speaking after Dr. Kyle, but so Robbie owes me on that one. But I will certainly do my best. So thank you for the invitation to speak today. I am from California, but actually your director of your cancer center here, Dr. DiPerzio, was my first mentor and the one who actually convinced me to go into stem cell transplantation when he was in Rochester. We both made the wise decision to leave Rochester, New York, I think after one too many winters. And ended up in obviously different parts of the country, but it's very nice to be back and work with Dr. Veej many times as we both compete in regards to our transplant programs and volume and hopefully innovation of what we do. So I was asked to speak about stem cell transplantation and myeloma. Dr. Kyle sort of gave you the history of it, and it's always nice to know some of the history and where things are. And so speaking of history, when I came to City of Hope, we actually did about 200 transplants a year. We did most of those transplants for a disease called chronic leukemia. We wouldn't transplant anyone over the age of 65. We wouldn't do a transplant from a donor in anyone over the age of 55. You know, and then there's a joke in the transplant field, as your chairman becomes older, so does your upper age limit of transplant. So, and you can see that's probably true, because the numbers of transplants we do in patients of older ages has gone up and gone up. And, you know, certainly, at least for us, and I would guess WashU's the same, we have no upper age limit for transplant. And in fact, if you look across the United States, we do about 8,500 transplants for myeloma. We do about over 500 for those in patients over the age of 70. And so really kind of what Jenny said earlier, staying fit is important in your disease. And really what we look at is not a chronologic age. We look at what we call physiologic age, you know, and are you strong enough to tolerate a transplant? I mean, I can tell you, there's a 74-year-old in my spin class every morning, and he's always beats me in this pursuit game we have. So again, it's not an absolute number at all. So this is a slide just to kind of show you survival is getting better and better for patients undergoing transplant, but obviously all of us in the field want this curve to be up here and to stay up here, and that's kind of our goal as we work towards it. Some of the things, you know, in myeloma change over the years. There's some, you know, parts that are extremely controversial, and we still don't have a clear answer, but the general paradigm is about the same. And Dr. Wiles, I believe, is probably going to talk about this part of things, induction therapy, and the many, many options, as Dr. Kyle mentioned, many, many new drugs out there now, and how do we use them and incorporate them. This is a hotbed topic here, consolidation therapy, you know, among myeloma doctors, both in the US and in Europe, and I'll show you some of the trials that is why it's so controversial, because we have very differing data. I think the one thing we agree on is maintenance therapy, so this need to stay on long-term continuous therapy. What we don't agree, or what we really don't know, is what maintenance therapy is best. How long do you give maintenance therapy? And what do you use to guide those decisions? So I'd say certain tenets hold true. So first of all, combination chemotherapy. So 3 drugs right now is pretty much the standard as of, I would say right now, being May of 2019, but perhaps next year that will change, and we have many trials ongoing, in fact, using 4 drug combinations, so incorporating some of the immunotherapy options that we use in more advanced disease. So I said we still don't know which 3 drugs are optimal, and what is really our goal of therapy. And Jenny alluded to adaptive. You know, they have done a big work in the field in terms of minimal residual disease, so finding very, very low numbers of myeloma cells in the body. And is our goal of therapy to get to the point where patients have no minimal residual disease? and how do we get to that point? So why is minimal residual disease important? You know, it's kind of like our standards are changing in terms of the numbers are getting better and better. It's kind of like, I don't know how many of you kids apply to college. It's something we all talk about all the time now. You know, when we got into college, it was a lot easier. Now my SAT score wouldn't get me in anywhere, right? So it's the same kind of thing in the myeloma world. We used to be happy with this, getting this complete remission, but now we're not happy with that, right? We need to get deeper and deeper and deeper responses, because we think when we get to this point, this is when we're going to be able to use the word cure more and more for patients. So the big thing is, how do we get to this point? And so the one thing I'm going to talk to you about is using stem cell transplantation to help get us down to even lower amounts of disease in the body. So some of the questions we always get for patients when they come in for a new consult, for example, I'll be talking and I'll spend 40 minutes and I say, do you have any questions? And the first question they'll say is, well, my doctor sent me here for a bone marrow transplant, but you're talking about stem cells. So that's the second question, is patients, you know, always say, oh, my sister's willing to donate, my friends are willing to donate. So this question about using your own stem cells versus using someone else's. Other common questions are, is transplant safe? You know, people hear a lot of myths like, oh my gosh, I heard it's very, very risky. I'm going to be, you know, in isolation for a month and then I won't be able to leave the house. And then probably the other question people ask a lot is, well, it's, you know, no matter how we paint it, you know, patients always say, well, it doesn't sound good. What's the benefit of doing this? And is there a benefit? And that's the things I wanted to talk about. So first, some level setting. The idea, first of all, what is a stem cell? And you probably see many, many ads for different things, you know, stem cells for your arthritis in your knees, for example, stem cell cream for your face. So there are many, many different kinds of stem cells. The kind I'm talking about is hematopoietic, or blood precursor stem cells. So what's so unique about a stem cell? A stem cell can differentiate, so turn into other things, but it can also reproduce itself, so self-replicate. And so the ones that we collect are hematopoietic stem cells, so they replicate and they also turn into all the blood cells you see in your bloodstream. So what are the principles behind stem cell transplantation? So there's two main concepts. The first idea is, in an autologous transplant, which is the mainstay of myeloma therapy, the treatment is really not the transplant. It's just the ability to use the high-dose melphalan that Dr. Kyle mentioned, which will basically kill all the cells in the marrow. The way we get around it is by rescuing people with their own stem cells they've collected ahead of time. So the cure or control of the disease is not from the transplant, it's from the chemotherapy. Now, in contrast, allogeneic transplant, using transplant from a donor, either a family member or unrelated donor, you're counting on that new immune system from the donor to be part of the way you control the disease. But because of that new immune system, you have other complications, something called graft versus host disease. So you need to keep people on medications that suppress their immune system after the transplant. So in this case, the cure is really coming from the new immune function and not from the chemo itself. So what's the rationale for these treatments? So the rationale is actually fairly simplistic. You increase the dose of chemotherapy, you kill more cancer. But at some point, you're going to get to this point where you start affecting other organs, right? And the biggest organs that we think about, your liver. Your liver is where you detoxify a lot of chemotherapy. The other organs that tend to get affected a lot, heart and lungs. So, you know, we try to be not on this part of the curve here. This is really where, when we do transplants for leukemia, we're getting very close to this, because we really need to give very, very intensive therapy, because we don't have the advantage of all the other drugs we have in myeloma after the transplant, for example, with maintenance therapy to help us. But in myeloma, we're really more down on this part of the curve here, where the chemo we're giving can affect the bone marrow, but hopefully not affect too much of the other organs. Why is that important? And I'll show you, because how we've now moved where we do our transplant, for example, as it's become safer and safer. So when I started in this field, when I was an intern, we would take people to the operating room and collect their bone marrow from their hips on each side. So if you think about the bone marrow biopsy you had, right, we would instead make 50 punctures. Well, we'd go through the same hole, but get 50 aspirations on each side. So you can see why we would have to put people to sleep for that. But obviously the things have changed now, and instead we collect stem cells from the bloodstream. So we bring people in, we give them shots of something called Neupogen that stimulates their bone marrow, and those stem cells get moved from the bone marrow into the bloodstream. We hook people up to a machine, and it's a big centrifuge. It spins off their blood, and we collect those stem cells. And then we freeze those stem cells for use at a later point. So now what happens after this? So I'm going to talk about a little kind of few issues that often come up. So I'll talk to you a little bit about the transplant, but then also what do we do after the transplant? So there is no standard therapy, and that's why Jenny's point in terms of HealthTree and individualizing therapy is important. Because we do think about the risk features of people's disease when we make these decisions, for example, in terms of consolidation therapy. And in terms of maintenance therapy, we also use that for example, people with more high-risk disease. We may advocate for a more intensive maintenance strategy. We may use different drugs for maintenance. So all these things are very important to us. And certainly we still don't know the answer for all these things, so clinical trials are still a very important part of the transplant world. So I thought I'd focus on sort of the common questions I get when people come to see us. The first one is, do I still need a transplant? We have so many great drugs now. I believe there's about 15 drugs that have been approved over the last decade for myeloma. So is there a point to transplant? So one of the studies we have was done between the United States and France, the IFM Dana-Farber trial, that looked at a very common regimen. Some of you may be on this regimen, RBD chemotherapy. Everyone had stem cells collected, so it allowed people options. And then half the patients went on to get a stem cell transplant. The other half went on to get 5 more cycles of RBD. And then patients were followed. Everyone got maintenance therapy with Revlimid. Now you can see it's actually type it. They got it for 12 months because this was the French view is short maintenance. The US view and the US portion of this trial is still ongoing. Patients actually stay on maintenance indefinitely. And the early readout of this trial from the French portion suggested that if you did a transplant earlier, you had a longer progression-free survival, or a longer time without myeloma as a way to think about it, than if you got just RBD chemotherapy alone. But on the other hand, overall survival was no different, at least at 4 years for patients. Now, having said that, it's important to understand about 80% of these people who got RBD ended up getting a transplant when the myeloma came back. So for many of us as transplanters, it tends to be less of a question of transplant or no transplant, and more a question of do I do transplant early, or can I delay it till a later time? And I have to say, our center at least, we have given the patient options of just collecting and storing stem cells. And that was a change in our policy about 3 or 4 years ago. Some of it is insurance dependent, though, and certain insurers will allow that versus other ones will only pay for collection if you're going to transplant, for example, within a set period of time. But that is certainly something now that we've thought about as part of our paradigm. The next question is, okay, so I've had the transplant, what happens next? What do I do after it? So these are kind of the options. So tandem transplants, probably the most intensive option. So collecting enough stem cells for 2, and then doing those 2 transplants within about 3 months of each other. The other option is consolidation therapy. So consolidation therapy is sort of an intense, short amount of chemotherapy after the transplant, and then maintenance therapy, which is long-term, low-intensity treatment, ideally something that's convenient as well for patients without a lot of side effects. So first, the question of consolidation, and why is it so controversial? It's controversial because there was a trial in Europe where everyone got a regimen that tends to be common in Europe, VCD, so Velcade, Cytoxan, and Decadron. And why is that important? It's important because it's not a regimen we use as much in the United States. One group of patients ended up getting a transplant and then getting a second assignment to either consolidation or no consolidation. And what they found is, in fact, that the patients who got 2 transplants seems to do, in fact, the best, especially patients with high-risk cytogenetics. So this raised the question, maybe doing a tandem transplant is better, especially if you have high-risk cytogenetics. And in fact, they do that in select cases in Europe. On the other hand, the US, we did an enormous trial here, 750 patients. Most of the patients got RBD, so a different induction regimen at the beginning, and then they got assigned to 1 of 3 arms. One arm just went straight to maintenance. One arm got consolidation, and one arm got 2 transplants. So the question was for us, in the United States, treating patients the way they get treated, what's the best thing to do after your transplant to prolong your remission? And surprisingly for us, all routes were equal. So in fact, doing 2 transplants was as effective as doing 1 transplant followed by maintenance Revlimid chemotherapy. And so with both in terms of time without myeloma as well as in terms of overall survival. So that's why in the United States, you see less of a push to doing tandem transplant and also less of a push to doing consolidation therapy. And generally, the standard approach is doing a single transplant followed by maintenance therapy. Some of the other things we've looked at, and I get this question a lot, is, what about using a transplant from a donor? So we've done that trial as well in the United States. And again, it has certain attractive theoretical advantages. You have this new immune effect. Certainly some of the longest and probably the most cures we've seen in myeloma have been with transplants from donors, but at a higher price. And the higher price is risks of the transplant, so mortality. So if you do a transplant from a donor where you completely wipe out the immune system and the bone marrow, what we call an ablative transplant, the risks are about 20 to 40% of not surviving because of complications. If you do a mini transplant using very low dose therapy and just using the new immune system, even that one has about a 10 to 20% risk. So overall, the numbers come out the same, that basically using a transplant from a donor versus using your own stem cells, the survival is the same. So we tend to not use this approach any longer outside of clinical trials. So now just to get into the weeds a little bit about transplant. So we talked induction therapy, most people get with their local doctors. They then come to our center and we give those shots. I talked about Neupogen. We put in a catheter, so a tube that we tunnel under the skin that we use to collect the stem cells. The stem cells are then frozen in a preservative called DMSO. It's the stuff they use on horses, actually, so the smell's familiar to people. And then we bring people in usually about a week later. And I say bring in, and we've actually moved our transplants to the outpatient setting now. So, there's a joke, being in the hospital is the worst place to be sick, and it's true in a way, actually. So we have an outpatient hospital on campus, and we have apartments on campus, and patients come in, they get their high-dose chemotherapy. It takes about 2 hours with a drug that Dr. Kyle talked about, the melphalan. They go back to the apartments. They come in the next day, we thaw those stem cells out, give them back to them. That takes about 20 to 30 minutes. We watch them for a few hours, they go back to the apartments. And then they come in every day to be checked on, have blood counts checked, monitor for side effects. Sometimes they need infusion of blood cells, platelets, potassium, magnesium, fluids, and things like that. Takes about 11 days for those stem cells to kick in, so patients are there with us for about 2 weeks. And what we found, certainly for our center, the outpatient setting has been tremendous for patients. They like being able to have more control, go home. If they live close by, they even go home. Sleep, cook the meals they want. No one's waking them up at 3 a.m. And even just walking back and forth from the apartments, it's sort of a way of making you get exercise too, versus, in the hospital, stuck in your bed alarm goes off before you can get out of bed, all these kind of things. So it's been tremendous for us for patients. Now, after the transplant, patients go home, they come back and see us generally a few weeks later. About 6 weeks after the transplant, we repeat the myeloma test to see what has been the response to transplant. One note of caution, it can take up to 3 months to get it, really see the full benefit of transplant. So, don't always be disappointed at 6 weeks if the numbers are not where you want them to be. And then we talk about maintenance therapy. Which, as I said, is low-dose treatment to hopefully prevent the disease progression. But we also recognize it's no benefit if you're taking something that's making you miserable, you can't get out of bed, you can't function, and you can't go back to as close a normal life as you can. So those are our goals with maintenance therapy. And what drugs do we have? So you have a variety of choices, as I said, and that's why this is important in terms of individualizing it. The most data is really with Revlimid or lenalidomide. We have 3 studies suggesting that if you take Revlimid after your transplant, you can reduce the risk of the myeloma coming back by about 50%. We combined all those studies together and also showed that it can improve survival. But unfortunately, there is no free lunch. And one of the issues with Revlimid that I'll show you is a risk of second cancers. It's small, but it is a notable finding. Other choices have been studied, less well studied, but certainly something we use is Velcade. And we have one trial suggesting that if you use Velcade as your maintenance strategy, it can also improve the time in myeloma remission. And most recently, ixazomib, the oral proteasome inhibitor, a trial comparing it to observation suggested that using ixazomib can also reduce myeloma remissions. So these are the things that we don't know, though. So first of all, we do know in maintenance, improve time without myeloma. It can improve overall survival. It does have toxicity, though, so effects on blood counts, second cancers, as I talked about. And let's not forget the cost of maintenance therapy, as these drugs are very expensive. What we don't know is, should everyone get maintenance? What drug to use? How long to give it? What happens if the myeloma comes back if you've been on lenalidomide, for example? Can you respond to just increasing the dose of lenalidomide? And that's something, in fact, we often do. So we do have this meta-analysis that suggests if you take lenalidomide, it basically can improve survival by about 2.5 years after a single transplant. So lenalidomide was approved by the FDA in part on the basis of these results as a maintenance strategy. This is a trial that I'm very excited about. We've been working on this trial for 3 years, and it's going to open hopefully at the end of this month, because it's going to try and answer these questions. How long should I take maintenance? What's the best maintenance combination to take? And what about MRD testing? Can I use that? And you'll see in your packets that thing about adaptive and the questions to ask my doctor. And one of the questions to ask your doctor listed there is, how are you going to use this MRD testing to guide my treatment decision? And right now, we don't know. Hopefully, this trial will help us answer that. So in this trial, everyone's going to get a transplant. Half the people are going to get Revlimid. The other half are going to get daratumumab, that antibody that Dr. Kyle talked about, plus Revlimid. Everyone's going to get it for 2 years. 2 years, if you're MRD negative, we're going to randomize or assign people to either continuing therapy or stopping therapy, and then follow patients. So this will hopefully allow us to answer the question, first of all, now with the use of antibodies, are there better maintenance strategies? And in fact, we're going to use subcutaneous daratumumab in this trial. And secondly, if you become MRD negative, can you stop treatment? So we're very excited about this trial. This is a huge trial, 1,000 patients. So, we certainly encourage you to talk to your doctors about this. We're going to allow patients to enroll even if you've already had a transplant. So it gives patients multiple opportunities to get into the study. Obviously, these are some of the side effects of maintenance. It is immune suppressive. It affects blood counts. Many of you on it, know in terms of fatigue probably is the biggest thing I've seen. Diarrhea on patients on long-term Revlimid, risk of blood clots, and this long-term effects of risk of second cancers. And you can see here, this is risk. It's not high, but it's there, and it's about 2%. in terms of other blood cancers, and also in terms of solid tumors. So what we tell patients is the things you can do is certainly don't forget about the rest of yourself. You know, I tell patients it's like you come to the hematologist, but you still don't forget about your colonoscopy, your mammograms, routine health screening. You know, our job is we obviously monitor blood counts so that we keep an eye out for any suspicious things that worry us that could be portending risks of blood cancers. This just lists some of the other things you can do and talk to your doctor about. I won't read them all in terms of some managing these side effects. And there are many, many different homeopathic remedies as well, and different things people try, especially for the muscle cramps. This just gives you a sense that we don't have the answers yet because there's so many clinical trials still going on using different maintenance strategies. One of them is listed here, Dr. Veach's trial that we actually put a lot of patients on that allow patients to either get Ixazomib or Revlimid as maintenance therapy, and then many other strategies ongoing. So in summary, what we know is certainly a transplant remains a backbone of treatment for myeloma. Maintenance therapy also is a backbone strategy. But again, many questions remain to be answered in terms of maintenance strategy. But part of our job is also to minimize toxicity and maximize quality of life for patients while they're on maintenance therapy. We have many things we don't know. Transplant early versus transplant late. How do we still reduce the risk of relapse? So in spite of these intensive therapies, patients still continue to relapse. So we have multiple strategies going on. One of them is one that I'm very excited about. We're going to open through the BMT CTN is for patients with particularly high-risk myeloma. We're going to do a CAR T-cell therapy after their autologous transplant. And then monitor patients and try to incorporate the latest and greatest things into our transplant strategies. And then obviously long-term toxicity remains the backbone of therapy.